get started. We can, I assume people will be trickling in, but everyone, I'm Archie Pala, I'm from Stanford. You all know Jenna Kahn from OHSU. Welcome to the third session of Rover. I think many of you have attended the past couple of sessions that we had. But for those students who are new, this is basically a series Jenna and I are hosting this summer while many away rotations are on hold to help provide some education to you all and help you all get exposure to faculty and institutions around the country. So today we're excited to cover the topic of head and neck. Before we introduce our panelists and moderators, I just wanted to briefly review the format. So we'll have our moderators and faculty go through some head and neck cases with you all. This is intended to be interactive, so we'll have poll questions throughout. Please participate in those. And then at the bottom of the Zoom, you'll see the chat function. So if you have any questions, feel free to send them over chat. Just make sure that it's addressed to both the panelists as well as the attendees so that everyone can see your questions and benefit from the answers. Let's see. And then before we get started, I always forget, but I just wanted to thank Navjot Sandhu, who's my admin. She's on the call and she's really been key to setting all of this up for everyone. So thank you, Nav. Anything else, Jenna, that we need to add in terms of logistics?
No, not that I can think of right now.
Oh, I'm sorry?
Not that I can think of right now.
Okay, so I'll hand it over to Jacob Miller and Chris Daig, our moderators, who can help introduce the panelists. And I think one fun thing that will be good for the introductions is if you can introduce yourself and maybe share a little bit about how you became interested in rad onc or you know, why you enjoy treating head and neck.
So our panelists today are Dr. Koifman from the Cleveland Clinic, Dr. Anderson from the University of Iowa, Dr. Beadle from Stanford, Dr. Sangvi from UCSD, and Dr. Skinner from Pittsburgh. Each are head and neck radiation oncologists. And maybe Dr. Anderson, do you want to start, introduce yourself and talk about why you're interested, why you became interested in the field and why you like head and neck?
Sure. So I'm Karen Anderson. I'm from University of Iowa. I learned about radiation oncology when one of my senior medical student friends was going into the field, and he exclaimed that it was by far the coolest medical specialty and nobody knew about it. So it was a great, very interesting field to explore. I solidified my interest in the field when sadly my mother-in-law was diagnosed with a glioblastoma brain tumor during my second year of medical school. And so during that time of helping to care for her, we certainly learned about radiation oncology and how it was part of her care. And of all the doctors that I met in following her to her appointments, the radiation oncologist was certainly the one that took the most time to explain things to us, was the most empathetic in their interactions with my mother-in-law. And the radiation therapist even sort of let me come into the treatment machine and showed me how she was going to be set up and what her plan was going to look like. So I thought that was the coolest thing ever. And then did some a rotation at our home institution and away rotations, and I was absolutely hooked. As far as going into head and neck radiation oncology, I trained at Cleveland Clinic a couple of years ahead of Dr. Koifman, and we had excellent head and neck training there. And when it came to job opportunities, my top priority was to get back to the Midwest because that's what where our family was from. And it turned out that the job opening here at University of Iowa was for a head and neck position. Coming out of residency, I'm not sure I said that was my first choice because head and neck patients are complicated and certainly sick and have a tough time getting through their treatments and things. But I was confident in my training and have absolutely loved it. I love that so during treatment, you can see the tumors melting away. You can feel the lymph nodes getting smaller. It's super fun to scope people. And they're a really interesting group of patients, and I've loved caring for them, and it's been a very exciting career overall. So
Thank you, Dr. Anderson.
All right, and I'm Chris Dyke. I'm a resident at OHSU. I will be introducing Dr. Koifman from the Cleveland Clinic. If you could just give us a brief introduction and why you chose radiation medicine, perhaps head and neck.
Sure. Hi, guys. Sorry I was a little late. Technical difficulties. Thanks for putting this together. This is super cool. And I trained a few years after Karin, so I just wanted to follow in her footsteps. Head and neck is head and neck radiation oncology is wild and awesome. But I think rad-onc in general it's the coolest field for shiz, because like Karin said, I always wanted to do oncology. I debated surg-onc, med-onc, rad-onc. I didn't do surg-onc because I wanted to see my kids. And it's harder that way. And I remember in medical school, I was so worried that the future of oncology was all going to be just molecular therapies. Radiation was going to disappear. So I was like convinced that maybe I should do that. And then I did my rotation at Yale in radiation oncology, and Ben Smith, who was the chief resident of the time, who's now a breast attending at MD Anderson and just one of the best human beings out there. He was like, no, Shlomo, no, it's not going to disappear, don't worry. And lo and behold, even with all the advances of molecular medicine and immune therapy and all of those amazing things, radiation is getting more and more important, especially in the curative space. You think about SBRTs, certainly, head and neck cancer, which is really cool. And then head and neck, I trained with Dr. Saxton the way Karin did, and he was like a legend who trained with Fletcher at MD Anderson. And he, just wisdom, and there's something to head and neck that the stakes are high. You either love head and neck or you hate head and neck. You're not neutral about head and neck. There is no neutral about head and neck. So I loved it. So happy to be a part of it.
And then Dr. Beadle, could you introduce yourself?
Sure. Thank you, Jacob and Chris, and thank you to Archie and Jenna for setting this up. As Jacob said, my name is Beth Beadle. I'm a head and neck radiation oncologist at Stanford. I got into radiation oncology because every member of my family has cancer, and I spent a lot of my childhood in and out of offices, including my grandfather, who was diagnosed with pancreatic cancer when I was 6 and was treated at the University of Wisconsin and then at Mayo, and after that, everybody else. So I was always familiar with oncology and the importance that oncologists play for both patients and families. And then through my education, I stepped through all of my studies on sort of the basis of physics. And when I got to medical school, I wanted to do something that had an intervention. I wanted to be able to fix things and do everything that I could to help patients. And so the intersection of those was radiation oncology. So it's a very scientific field. There's a lot of physics, a lot of biology, and a lot of compassionate patient care. You get to know patients really, really well. And oftentimes they consider you their primary doctors. So it's something that means a lot to me. In terms of head and neck, I remember my first patient as a medical student in radiation oncology was a head and neck cancer patient. And I really, as Karin said, it's really rewarding to see a response, to be able to do careful physical examination and not depend simply on an image, and to have an intervention that is largely successful, although sometimes not, and to be able to work with other disciplines, including medical oncology, surgery, pathology, and radiology so closely to try to get the best outcomes for these patients. So it's really rewarding. I trained at MD Anderson, I stayed on as faculty, and I moved to Stanford a few years ago, and it's just a really great opportunity to help patients and make changes in cancer care. So I'm glad that you guys are all interested.
Thank you, Dr. Beadle.
All right, perhaps Dr. Singhvi can give an introduction.
Yeah, thank you, Chris. Again, I want to thank everyone for hosting this such a great format for the students this year. So my name is Parag Sanghvi. I took a non-traditional route both to medicine and radiation oncology. So I actually majored in liberal arts and spent a fair number of years working at CDC in HIV/AIDS prevention, and really decided to go into medicine, wanting to be an HIV physician, and came into medical school intent on doing this. And just by serendipity, in my third year, ended up doing every possible rotation in oncology, surgical oncology, gynecologic oncology, and medical oncology during my core rotations, and just fell in love with oncology and the complexity of it and the multidisciplinary nature of it. And what I remembered at every tumor board was that the smartest person in the room was always the radiation oncologist. You know, she or he knew more about every cancer, whether it was staging or management, than anybody else in the room. So I was really impressed by that. And so decided to just walk into my med school's rad-onc clinic and said, can I spend some time with you guys? And on the very first day, the attending put me on to watch a cervical cancer implant, and then I actually got to do one. And so I loved the part where you could walk in and do procedures and see very complex patients. So I fell in love with radiation oncology, and I actually trained at OHSU under John Holland, who is just a master head and neck clinician. And I will say that I fell in love with head and neck really training underneath him. What I love about it is just, given the complexity of the disease, and as you will find, the morbidity of the cancer itself and the treatments that we deliver for this, I truly believe that really requires a level of compassion in caring that is it's really an honor to be part of that journey for your patients. And so I primarily do both head and neck cancers and heme malignancies here at UCSD. So thanks again for having me.
And then Dr. Skinner.
Okay, great. So I guess there's two questions, right? How did I get to radiation oncology, and how did I get to head and neck? So how I got to radiation oncology was I was in the midst of my PhD in oncology generally, studying angiogenesis in ovarian tumors actually. And I had literally no idea what I was going to do. Kind of wanted to do oncology, but the idea of inpatient medicine made me kind of nauseous. And the idea of cutting people up was the same. So somebody who actually studied head and neck at my institution is like, have you thought about radiation oncology? And he did some work with Kian Ang, who has since passed away, was a head and neck radiation oncologist at Anderson. I'm like, no, what's that? So this led to a few away rotations where I met, among other people, the illustrious Dr. Beadle, and eventually led to a residency in radiation oncology. Now, in regards to head and neck, I had some amazing mentors, including, again, the illustrious Dr. Beadle here. I did my training at Anderson and just had some amazing mentors within the field, both inside radiation oncology as well as without. And the study of head and neck cancer to me is fascinating, both clinically in regards to treatment, the definitive modality and a large portion of head and neck cancer, but also mechanistically. We have a number of different translational projects that are fascinating. We have HPV negative and HPV positive disease, which are different diseases, like dramatically different diseases, which we can both study within the rubric of head and neck. So that drew me to the field. So that's my spiel.
Wonderful, thank you all. Okay, so as Chris mentioned, he and I are residents, he at OHSU and I at Stanford, and I think with that, we can get started with our first case. Chris, do you want to take it away?
Yeah, thanks so much, and thank you everyone for joining. So the first case we'll do is an oropharynx cancer case. So the clinical vignette, so this is a 66-year-old self-identifying male. And the first question right off the bat for Dr. Koifman, what parts of the history are critical for your new head and neck cancer patients?
So that's a great question. my residents often hear me say actually something interesting about head and neck cancer that's different than many others, is that to me, other than the one-liner diagnostic line, you know, this is a 66-year-old guy with a P16, T2, N1, you know, right face of tongue cancer. Other than that, and maybe everything I care about is in their social history. So of course you need all the usual history stuff, but social history is just incredibly crucial in head and neck cancer, because as opposed to many other kind of types of radiation, these patients go through very intensive treatment, whether it's definitive or post-op, and knowing who they live with, how far they live, who's going to take care of them when they're sick. You know, are they smoking? Are they not? Are they going to lose their job by taking off work for a month or two? All these things actually are hugely crucial to the logistics. So usually my residents know past medical history, past surgical history, anything important I need to know, you know, have they ever had radiation, et cetera. But the social history, never ever skip a social history on a head and neck cancer patient. Now, in terms of the disease itself, you know, when you're looking at a 66-year-old guy and it's a head and neck cancer patient, probably 50% of the time it's going to be a young, healthy white guy who doesn't smoke or smoked a long time ago with a painless neck mass and minimal symptoms, because about half our practice is HPV positive oropharyngeal cancer. So you're looking to see whether that kind of patient fits that profile versus kind of a different profile. Obviously, the symptoms are crucial. You know, you know, are they symptomatic or not? And interestingly, with oropharyngeal cancer, many patients actually present without many symptoms. They just feel a lump shaving. So that's kind of important to know. And most of these guys, again, are healthy. If you see somebody coming in with bleeding and they're sick and they're losing tons of weight and things like that, it's not that common in HPV, and that also clues you into the natural history of the disease.
Thank you so much. And as you alluded to, this patient in particular has no past medical history or family history, and did just note a painless lump in the right side of his neck to his primary care doctor. So Dr. Anderson, how do you go about or approach your physical exam for head and neck patients?
Sure. So I gather quite a bit of information about my physical exam as I'm interviewing them. What is their general performance status? You know, how interactive are they? What is their mood, their affect? What's their understanding of the disease? And then sort of as they're talking to me, is their face working symmetrically? You know, are they hard of hearing? Is the lump noted on the right side visible to me as I'm sitting there across the room from them, talking with them, etc. And then as I have them move over to the exam chair, you know, do they have any difficulties getting up? What is their mobility? Can they get over to the chair fine, etc.? Is this 66-year-old someone who looks 66 or 86? And then as I'm examining them, I'm usually doing the head and neck assessment first. So I get out my otoscope, look in the ears, work my way around, kind of use the eyes and the otoscope light to examine the eyes, and move over to the other side. As I'm straight on with them, there again, any facial asymmetries, any particularly obvious skin lesions that could be a source of a problem for their right-sided neck mass. And then I'm kind of looking inside the mouth next. So how widely can they open? Does that seem limited in any way, suggestive of trismus? As I look inside their mouth, I'm looking at all of the oral cavity surfaces. What is the condition of their teeth? Looking at tongue mobility, does it seem tethered at all? Does it seem asymmetric in its musculature? Is there any sort of, you know, atrophy of one side of the tongue compared to the other? And then I'm looking more towards the oropharynx. Does the palate look even? Does it rise symmetrically? Is there anything in the tonsillar regions? And posterior pharyngeal wall, anything obvious going on there? And then after just sort of a visual exam, I'm usually using a gloved finger to examine the floor of mouth, the root of the tongue, palpating for any masses within the tongue and the tonsillar areas. And then I move on to the neck exam. And head and neck exam rooms are often unique in that they have a chair that you can actually stand behind the person. Kind of looks like a dentist chair, but the goal is to stand behind the person so that you are using both hands simultaneously on the same anatomic region of the patient and utilizing your mirroring fingertips to palpate the neck. And so you stand behind the patient, compare right versus left. Is there any asymmetry? Are there any lymph nodes or swollen glandular structures in the head and neck? And where is this right-sided lump exactly? How does it relate to the different levels of the neck as they're described in the anatomy books? Does this seem to be a glandular lump, or does it seem to be a nodal lump? And then I'm sort of determining by my exam, what is the size of this? How does it relate to the structures nearby? So for example, does it seem tethered to the underlying anatomy, or is the overlying anatomy abnormal? So is the skin dimpled and stuck to this node or discolored? And then I'm feeling for anything more subtle. So is there adjacent adenopathy above or below adjacent to this right-sided lump of the neck? I'll do examination of their heart and lungs, depending on what their review of systems is like. I'll address those in my exam as well. I'm also paying attention to things like the quality of their voice. Is there any hoarseness? Is there any stridor? Do they have some degree of dysarthria where they're slurring their speech, or there's sort of a nasal quality to their speech? So there's a lot of those kinds of things that I'm picking up on as I'm examining the patient.
Great, thank you so much. So for this patient, in addition to the many negative findings that you carefully described, all that was positive was this palpable 2 to 3 centimeter node in the right upper neck. And so the first poll.
At this moment, though, the question remains, do we have the opportunity in our office to scope the patient? COVID has made that more challenging at the moment, but our goal is to perform an endoscopy of this patient as well, especially if we're not seeing anything on our chair exam. We would want to perform endoscopy and evaluate the structures internally. So nasal cavity, nasopharynx, oropharynx, larynx, hypopharynx, and assess if they are related to this right-sided lump. And so that would be another part of the physical exam that's very important.
We're not allowed to vote. That's so mean.
Jacob's very tough. He's very tough.
Oh, I know.
No participation from the panelists.
All right. Looks like most of the answers are in.
Wow. Neato.
And so do one of the panelists want to describe what they would do next, and perhaps contrast that with some of the answers? So I guess I'll call on Dr. Beadle.
I was unmuting. So I think we have to think about what the best thing for this patient is, and then separately what the best thing for the world is. And those don't always overlap. So we have 4 imaging modalities that you gave us as an option. The ultrasound is the least invasive, so it just uses a probe to look at that one physical finding you have. And it's non-invasive, it can be done in the office, and it's the least expensive. It's also the most user dependent. So an ultrasound in different hands could come up with different results. And so sometimes people have ultrasounds of lesions like this, a lump in the neck, and get told it's a cyst, or someone will stick a needle in it and drain it. And then we see patients as oncologists several months later when it grows back or comes back and things like that. If this turns out to be a lymph node from an oropharynx cancer, which since this is the oropharynx cancer session is sort of a spoiler alert, sometime they can have necrotic centers, or they can have fluid-filled cysts, both of which can be mistaken on ultrasound. So I think it's an excellent and cost-effective way to start, but it's something where if you've got a feeling that it's something more than the ultrasound report says, you want to follow up again. The nice thing about an ultrasound is you can also use it to help lead a biopsy, so that the biopsy could go into a solid component of that lesion where your yield is going to be higher for a diagnosis. A CT scan with IV contrast is a good diagnostic scan for the head and neck. It will show if there's any abnormalities in the lump that you're feeling and if there are any suspicious findings, and also if there are any things in the rest of the head and neck, for instance, in the base of tongue or tonsils or things like that. But it is it's a study that costs money, that involves contrast where patients could have allergies, and it also gives a small but a real radiation exposure. PET CT and MRI are both much more expensive scans to do, and so for both of them have excellent outcomes and tell you a lot of information, but both of them are very expensive. And in a setting of someone with a neck lump without a diagnosis, it's probably going to be hard to justify doing something because you don't know that this patient has cancer. That could be a cyst or something benign right now. So I would probably lead with one of the first two because they're less invasive and less expensive.
Great, thank you so much. And of course, there's not a perfect answer, but in this case, an ultrasound was performed initially for the many reasons Dr. Beadle alluded to. And you can see two hypoechoic abnormal appearing lymph nodes. Perfect. Thanks, Jacob.
Are you radoncs doing this in your office or no?
Now, are you, Dr. Quickman?
No. I just wanted to know if I was, missing out on the greatness of the coast.
We have an FNA, we have an ultrasound FNA kind of on call. So if we see a patient who has a palpable node, we can have a team come and do it while they're at in our clinic, but I'm not personally doing ultrasounds.
Right, me neither.
I really should not be trusted with an ultrasound.
You tell them if it's a baby,
I thought I saw a baby.
how big the baby is. Yeah.
Yeah, exactly. I thought I saw a baby in there, so I really should never do that ever.
So Dr. Beadle, I know this is a limited scope and there's some fiber optics out, but could you comment on maybe some of the anatomy that you see on the scope that we did do with PPE on?
Sure. So as Dr. Anderson mentioned, one of the fulfilling parts about head and neck cancer treatment and evaluation in a radiation oncology clinic is we can actually use a flexible endoscope to evaluate the patient. So for these cases, we can anesthetize the nose with a topical anesthetic, and we can put a flexible endoscope in the nose. It goes through the nasal cavity to the nasopharynx, turns south, and then we can assess the oropharynx, larynx, and hypopharynx. So we can see if there's any mucosal abnormalities, any masses. We can see if the vocal cords are vibrating, and if they are even, if there's any aspiration. So we can do these procedures in the office. Also, as she mentioned, this is much more complicated in the era of COVID because this is considered a high-risk aerosol generating procedure. So different clinics have different sort of safety thresholds for this right now, I think, depending on where you are in the world. But no matter what, you should use PPE for this, and it really should be used as sparingly as possible. I think that since head and neck is a multidisciplinary treatment team, a lot of times people would come in and get a couple scopes in a couple days so that everybody could see their tumor. And now we really try to minimize that. So for this patient, we are now looking into the oropharynx. So you can see the epiglottis, and you can see you're looking not only for masses, but sort of irregularities in the mucosa, color differences and the like. And you can see that there's a small nodule in the right base of tongue. So when you do these in the office, that side that either Jacob or Chris is pointing out is the right side, and there's a small nodule there. Normally that would be more concave, like you can see on the other side, and that area between the epiglottis and the base of tongue is called the vallecula. And there seems to be a small lesion just on the side of the base of tongue extending into the vallecula. Now, when you do this in real life, you're going to ask the patient to stick out the tongue to see if that lesion is stuck onto the epiglottis, how far it goes into the vallecula, if it goes onto the piece of tissue that connects the epiglottis with the wall, which is called the pharyngoepiglottic fold, and whether or not it tracks down along that wall. So that can be done by having the patients say E and also stick out the tongue, puff out their cheeks and the like, so you can see how big the extent is. But that's what I see on the scope.
Perfect. All right. And so this was biopsied by FNA using the ultrasound. And the next poll is, has been alluded to, what organism is likely at play with this patient's cancer? All right, it looks like most folks overheard the discussion about HPV, and we'll talk more about that. All right. And so, Dr. Sanghvi, could you touch on how, based on your when you first started practice, compared to now, how HPV plays a role in your patients, and how do you counsel folks on outcomes based on their HPV status?
Yeah, absolutely. So I would say that one of the most important discoveries in head and neck cancer in the last 15 years really has been our improved understanding of the role that HPV, particularly HPV 16 and 18 subtypes, play as an etiologic factor for a variety of cancers. We've always known that about cervix cancer, but now recognizing its role in oropharyngeal cancers. So I would say when I was a resident, we in the early days of my residency, there was no HPV testing. So we treated everybody as without having any awareness of their HPV status. And now, if you look at oropharyngeal cancers in the US, particularly on the coast, over 90% of the oropharyngeal cancer patients that we see have, are HPV mediated. In terms of how these present, as compared to the oropharyngeal cancers in smokers and drinkers, oftentimes these primary tumors are very small and they have a higher nodal burden. As Dr. Beadle was mentioning, oftentimes these nodes can be very cystic in presentation or have central necrosis. And what we also know about HPV, that it is extremely prognostic in oropharyngeal cancers. So these patients tend to do far better, both in terms of their long-term disease control and their overall survival, compared to patients who have oropharyngeal cancers from drinking and smoking. So I'm sure we'll talk a lot about this. This is, the last decade has been very exciting in looking at how we look at, is it safe to de-intensify therapy for these patients who have HPV-mediated oropharyngeal cancers? And more importantly, how do we manage toxicities and mitigate both short-term and long-term toxicities in these patients? So.
Great, thank you. All right, and so we have two videos. One of the raw data from the PET-CT, and one showing the axial slices of the fused PET-CT based on the PET data that you see on the left and the CT that's acquired simultaneously at the same study. So Dr. Cushman, if you could, if you can see it okay, if you can describe what you see and what might be abnormal.
Sure. Just get out of my simulator room. So it looks like there's a small little T1 right base of tongue tumor corresponding to that area of the scope that we saw. And it looks like there is that right level 2 lymph node that looks partially cystic, FDG avid. Can you scroll up all the way? Do you have it higher? How far up do you go? So it's important to evaluate the retropharyngeal lymph nodes, which we could see right there. Probably want to go just a smidge higher, but they're usually negative, so I assume there's nothing there. Looks like it's just that single node. Is that right? Keep going down. Maybe there's that other one. Go down a little. Right there. Is that a vessel or is that a node? That's a vessel.
That's scrolling.
Okay. So it looks like it's probably a T1N1 early stage. We haven't biopsied this thing yet. So oh yes, we did. We got an HPV. So this is a T1N1 stage 1 HPV positive cancer, assuming that the rest of the body's negative. Can you just confirm on that whole body thing? Ooh, yeah, that's just the injection site of the arm probably, right?
Mm-hmm. Mm-hmm.
Okay. So yeah, this is a classic bread and butter thing we see in clinic all the time.
Perfect. So like you mentioned, this is a CT1N1, stage 1 oropharynx HPV positive cancer. And so Dr. Skinner, what treatment options would you routinely offer this patient?
In that, I thought there were a couple nodes in that neck, like one node right above the larger one. And that would kind of sway the way I think about this a little bit. If there were truly just one node with a very tiny primary, one potential treatment for this patient would be RT alone. But if there are multiple nodes in the ipsilateral neck, then you think about concurrent chemoradiation. Now, there are probably scores and scores of trials that this patient will be candidate for because, as has been mentioned previously, HPV positive disease does pretty well. And the long-term toxicity from radiation and chemoradiation is profound. So there are a number of different trials looking at various different ways to either de-escalate dose of radiation, to change the chemotherapy, to change the sequencing, or to add surgery. Now, at many institutions, transoral robotic surgery would be offered for this patient, TORS. And I think that I'm not going to skip ahead and tell you what TORS is because there's another question that talks about, asked another panelist what TORS is. But it's surgery, and that is done at many institutions with the goal of either de-intensifying adjuvant therapy or for some selected patients, no adjuvant therapy at all. Now the problem, or at least one of the problems, is that, for example, radiographically, we're not very good at determining extracapsular extension. So if you do surgery, you get a small tumor, but you wind up with pathology for ECE or gross ECE. Then you're kind of stuck. You have to do postoperative chemoradiation, at least not one trial. So then you've done trimodality therapy for a patient who is probably ill-served by such a thing. But that was a very long answer to a short question. So I think this patient could be managed non-surgically or surgically, and part of that depends upon your institution. So there.
Perfect. And Dr. Cushman, so can you describe what TORS is and how your institution selects patients? Or if he is busy, looks like he's walking around in clinic. Dr. Beadle, would you be able to comment on this?
I think he's back.
Oh, perfect.
Sorry, guys. What was the question?
That's okay. So Dr. Skinner talked about various treatment options and gave a good segue on how these patients are sometimes managed surgically.
Yeah.
And so I was just asking if you could describe TORS and how your institution tumor board selects patients for this.
So we are at the Cleveland Clinic, we're a little bit unusual in that we don't do a lot of tours. And the reason we don't do a lot of tours is not because our surgeons don't love it, it's because they're smart. And what that means is that the truth is HPV is hard because you're gonna have really good outcomes no matter what you do for this patient. And the problem with tours, however, is that lymph nodes, if you take this tumor out and it's a T1N1 and there's no LBSI and there's no perineural and it's one little node and there's no extranodal extension, you could probably watch that patient. And TORS monotherapy is fabulous. And if I think somebody can get away with just surgery, I always send them. It's pretty rare in oropharynx cancer to get away with just surgery. Typically, people are going to have indications for post-op radiation, and you're dealing with bimodality therapy at least. Whereas, as Heath said, you know, you might even consider radiation alone for this patient up front. And there are trials looking at reduced dose radiation, as he mentioned. But the real challenge is that if you operate on these people, we stink at judging extranodal extension based on CAT scans. And the reason that's important is because it's very common for lymph nodes, especially a couple centimeters in size or greater, to have extranodal extension on pathology. I would say this patient has about a 50-50 shot of having it. And the reason that's important is that if you find extranodal extension on the pathology report, then that means that not only do they have an indication for adjuvant radiation, but they have an indication for adjuvant chemoradiation. It's somewhat controversial. There are people that don't advocate for doing chemo in patients like this with ECE, and I would probably be one of them. But traditionally, by the book, if they have ECE, you give them chemoradiation. And then we've taken a patient that would do exquisitely well with single modality radiation or maybe chemoradiation, and you've given them now 3 modalities of treatment and intensified them rather than de-intensified them. So the ideal patients for surgery are either people that will get away with monotherapy only, or people in whom you do TORs who maybe they have multiple nodes and they would have needed chemoradiation, but by doing TORs, if they don't have extranodal extension, if they don't have big bulky nodes, if they have a high chance of getting a negative margin, you can get away with post-op radiation alone and you can avoid the chemotherapy. So that's why it's not that common a patient that you're going to get that, which is why we tend to do a lot of non-operative management for these patients. But if they fall into those categories, then that's when we advocate for surgery.
Great, thank you. In the interest of time, we'll skip the next question as it'll come up later. And the names may not match who I call upon because we might skip some questions. So we'll skip this next question. And then, so CT simulation. Actually, I'll go back to Dr. Anderson. If you could describe how you may set this patient up.
So this is a nice photo, but I would set them up slightly differently than what is displayed here. The patient that you see in the photo is laying supine, and they have this mask apparatus. It's called an aquaplast mask. It's made of a plastic that becomes flexible when it is warmed, and while it is warm and flexible, it's pulled over the patient's face. And in most cases for head and neck cancer radiation, face and shoulders. So we use a head and shoulder mask immobilization device for radiation simulation for these patients. And as that material cools and dries, it hardens and keeps the shape. And so this device is not protective in any way. It is used for positioning and immobilization so that as we give them daily radiation treatments, they are in a consistent position that to the position they were in at the time of scanning. So we would use a head and shoulder mask in a situation like this. I happen to also, what's fun about this moldable material is I would have the patient's mouth open and we depress the mask into their mouth with the tongue underneath to create separation between the roof of the mouth and the tongue area, so that as we're aiming radiation towards that back part of the tongue, we spare the roof of the mouth from unnecessary radiation. So this moldable material can be used for specialized positioning as well. But at University of Iowa, we're lucky enough to have a PET-CT simulator and MR simulators here in our department, and I use all three of those imaging modalities to scan the patient for radiation planning and targeting. And so the mask is made first, and then the PET-CT, excuse me, and MR images are taken with that mask overlaid on the patient's body, so that when the images are imported into the drawing software, the patient's position is as consistent as possible, as it will be at the time of their treatment delivery. So we use contrast, both CT and MR contrast, as well as the FDG, F18 contrast for the PET scan, and obtain those images for our drawing purposes, our planning purposes. The patient's probably holding a ring in their hands just so that as they let their arms relax, their arms don't fall off of the table, because these tables have to fit inside the treatment or the imaging machines. Other than that, it's just a cushion underneath the knees there. Sometimes we put a band around the toes to keep their feet from wiggling a lot as they're being treated, for example. But that's kind of our simulation process.
Thank you. All right. And so this is the axial CT that was acquired. And it was a video, it might not be playing. Yep, there we go. And Dr. Let's see, Dr. Beadle, would you be able to describe some of the axial anatomy?
Sure. So I think one of the most important things for head and neck is that it is a target-rich environment for normal tissues, and if you don't contour it to avoid it, you're not going to avoid it. And so we spend a lot of time not only delineating where the tumor is and the at-risk areas where the tumor could go next, but also the normal tissues that we want to make sure that we avoid. And there is differing data, differing quality of data on what different tissues can avoid, and we're always safe, but we want to make sure that we do the brain, the brainstem, the inner ear, the optic structures, the salivary glands, the constrictor muscles, the mandible, the larynx and laryngeal structures, the submandibular glands, the esophagus, all as potential avoidance structures. And some of those are more meaningful than others. For instance, you don't want to compromise on brainstem or spinal cord because overdoses to those areas could be deadly. But on the other hand, there are style points for the others, as you want to make sure you have good coverage of the tumor, but as much as possible, you want to avoid the salivary glands so the patients don't have xerostomia or have minimal xerostomia moving forward, the constrictor muscles, and the larynx also for swallowing function moving forward. So again, the priorities of those differ. The risk of those differ depending on where the tumor is. Since this is a low base of tongue tumor, we definitely want to make certain that we have coverage of that lesion with knowing that it may move a little bit when patients swallow during treatment, but we also want to be cognizant of coverage and also sparing the constrictor muscles and the larynx as much as possible.
All right, this is a video of what was drawn as GTV, or gross tumor volume. And that's okay, we saw it pretty well on the PET-CT. And so I think we're up on to Dr. Sanghvi. What would typically for this patient be your high and low risk nodal volumes, and if you treat this any differently if this were a well lateralized tonsil tumor in contrast to a base of tongue tumor?
So historically, for a base of tongue tumor, you would have included bilateral levels 2 and 3. So these are the lymph nodes that sit next to your sternocleidomastoid muscles, going from the base of skull all the way down to the level of your larynx as high-risk volumes, and then the level 4 nodes and the retropharyngeal nodes as your low-risk volumes. But in HPV-mediated oropharyngeal cancers, as we know that these patients do so well, there's an increasing trend to just treat the involved nodal basin in the high-risk volume. So in this patient, that node seemed to lay right at level 2, perhaps going a little bit into level 3. So you could certainly make the argument as done here, treating the level 2 and 3 nodes in the high-risk nodal volume. And then you can see that on the ipsilateral side, you've covered the retropharyngeal nodes and the supraclavicular nodes in the low risk volume. And then on the contralateral neck for this base of tongue patient, you have levels 2 through 4 as the low risk nodal volume. Now, if this were a well-lateralized tonsil tumor, and by that we mean if a small tonsil tumor that does not extend into the base of tongue and has minimal, if any, soft palate involvement, we know that these well-lateralized tumors drain generally only into the ipsilateral neck. So for that type of a particular patient, you could certainly skip the contralateral neck and just treat the involved side only. We typically do this in patients who have, again, small tonsil tumors, and if they have either no nodes involved on a CAT scan or have, perhaps one node involved on a CAT scan. Once the number of nodes, if you have multiple nodes involved, even for a well-lateralized tonsil cancer patient, you have to weigh the risk benefits of omitting the contralateral neck.
Great. This is the patient's, so you can assume that the patient was treated with chemoradiation and did okay during treatment, but this is their 3-month post-treatment PET-CT. And so the next poll will ask what you all would do next based on what you see on the imaging. All right, we at least have quite a few respondents. It looks like SBRT looks like the favorable response. So we'll chat about that. Trying to spread around the questions. I think we're back to perhaps Dr. Koishman. What would you do in this situation?
Well, the first thing I would say is we as a field have done a great job selling how awesome SBRT is, because it is, but probably not in this instance. So it's very common, it's very complex to interpret post-treatment imaging, because like was mentioned, HPV positive disease is also an inflammatory disease. There's often a lot of lymphocytic infiltration and a lot of cystic components, and it's hard to differentiate residual tumor from residual inflammation. So basically what we look for on that 3-month PET-CT is if everything melts away and there's no PET avidity, fantastic. If something's growing and more PET avid, they got to go for salvage resection and be restaged for potential distant mets or some kind of systemic therapy. But what usually happens is it'll melt really beautifully and the PET will get better, but it won't go away completely. There'll still be a little bit of residual uptake and a little bit of a node that you can see. And the reason for that is, cancer goes away with radiation, cysts does not. So you're not going to get rid of that fibrotic scarred mass. It's just going to kind of shrivel up and turn into a scar ball. So on this scan, typically we almost always observe, because your pre-test probability of this being residual disease is so low, you kind of know that this patient is probably going to CR. So essentially what we do is we try to characterize this. I would look with a diagnostic CT scan, not just a PET CT. It looked to me like there were calcifications. I couldn't tell for sure, but if there are, that's a very good sign. It's very often for these cystic lymph nodes to calcify, which means it's not tumor, it's just dead calcified stuff. So I feel that on this, we would observe almost all of the time and just get a short interval scan with another. We try to, it's really important, I think, PET CTs give you great functional information. They don't give you great structural anatomic resolution. For that, you really want either a good contrast enhanced CT or an MR. And I would, in conjunction with my PET CT, I always get a diagnostic CT, and then I follow them with the diagnostic CTs 2 or 3 months later. And as long as that node is kind of shrinking, as long as it's not getting worse, you know, then we would just chalk it up to a CR and watch. Again, if it starts to grow, if they get symptoms, et cetera, then that would prompt salvage, which is usually a neck dissection.
Great, thank you. We can, I think, move on to the next slide. I think this is the last slide of this case, and we took up so much time in this case, covered a ton, but Dr. Skinner, this is a video 8 years later of this patient who was treated for right lower lobe pneumonia. And he was having an increasingly difficult time swallowing thin liquids and underwent a modified barium swallow. Would you be able to chat a little bit about what might be going on in the video and how you counsel and manage these folks?
So as mentioned earlier, you know, one of the real aims of what we do is that radiation is the gift that keeps on giving for the rest of your life. And one unfortunate gift that we give is long-term swallowing dysfunction, which I think is what this patient has. I think that they have a pneumonia secondary to aspiration. So what is that? So that's stuff going down the wrong hole, basically. So as opposed to swallowing fluid and swallowing saliva as one should, winds up in the lungs. It's not, one is swallowing not as well as one should, and it's hard to protect your airway. So this is the impetus for a lot of what we're doing in regards to de-escalation protocols for HIV-positive patients. We know that if you follow patients long enough, a lot of them will have some element of swallowing dysfunction. Now, what do you do? So, I mean, there are a number of different techniques that one can do to try to protect one's airway in regards to swallowing. But if something like this is progressive, if it cannot be mitigated, swallowing exercises, swallowing boot camps, something like that, in game, if you're continually aspirating, you wind up with aspiration pneumonia after aspiration pneumonia. Patients can wind up with a laryngectomy. Like they can wind up with an enormous surgical procedure, not because of cancer or anything, because they have this horrible aspiration. Now that's obviously the worst possible endpoint. We don't necessarily wind up there, but it's something that we as radiation oncologists have to think about. These patients, it is the gift that keeps on giving, the negative gift that keeps on giving. And that's why I think that the research that we're doing to try to mitigate toxicity, particularly in the HIV-positive patient, is so important. Because I think we now have better follow-up on our patients, and we realize just how much damage they do in curing the malignancy. And the HIV-positive patients, they live longer, which is a glorious thing, but they're living longer. They're typically younger, and they're living longer with the side effects that we've given.
All right, thank you to all the panelists going through this very common scenario. I believe this is the last slide. We can move on to the next case, which Jacob will go through.
Thank you, Chris. So switching to a different disease site, oral cavity cancer. So this is a case of a 50-year-old man who presents to clinic with a painful, non-healing left oral tongue ulcer that you notice several years back, but it's kind of grown and become more bothersome over time. And recently, he's been having difficulty chewing because it's painful, and he subsequently lost weight. Brief overview of his history. He has a history of COPD related to possibly to his 30-pack year smoking history. He drinks 2 beers a day. He works as a musician. Going back to our head and neck physical exam, when you examine the patient on the transoral exam, you note a 2 to 3 centimeter area of ulceration along the left lateral and dorsal tongue. It's tender to palpation. It has some depth when you feel it, and it extends to, but it doesn't involve the floor of the mouth. His tongue was mobile, it wasn't deviated, and when you feel his neck and do your thorough neurological exam, you don't palpate any enlarged lymph nodes or appreciate any cranial nerve deficits. So there's just an example of what this oral tongue ulcer looks like that's been bothering him. And subsequently, you, just like the previous patient, send him for a biopsy. Biopsy shows invasive, moderately differentiated, keratinizing squamous cell carcinoma. On the biopsy, the carcinoma extended to a depth of 7 millimeters. There wasn't any perineural invasion or angiolymphatic invasion. And then the patient ended up going for an MRI to further evaluate this lesion. Okay, so here's the MRI. We have the axials here, both T1 and T2. And the MRI showed this left oral tongue mass without any involvement of the mandible. A left level 2 lymph node did measure 8 millimeters in short axis that you didn't palpate when you were in clinic. And a chest CT showed metastases. So you have this patient with this oral ulcer, maybe an enlarged lymph node. What's your initial treatment recommendation if you're going to manage this patient?
I just love how these images highlight what we can see on MR for head and neck. I'm kind of surprised that we don't use it more often in the diagnostic setting. But this can point out how beautiful MR images can be for the radiation planning process. Look at all those teeth that are right next door there that you can, still see the tongue musculature next to the teeth, which would be covered by a dental artifact in most CT with contrast settings. So MR is awesome.
Great, and so we've got a number of respondents. Let's share the results of the poll. So most people responded a partial glossectomy and a left neck dissection. Nobody said a total glossectomy, and then there are some responses for induction chemotherapy and definitive chemoradiation. So the patient ends up meeting a head and neck surgeon, talks about surgery, and then just as most people responded, the head and neck surgeon did recommend a partial glossectomy and a left selective neck dissection. So going back to the panel, maybe Dr. Koifman, why did the head and neck surgeon recommend a left neck dissection? Why might certain lymph node levels be involved? Why not operate on both sides?
Great question. So a really important principle in oncology is therapeutic window. And it applies to radiation, to surgery, to chemotherapy, to anything we do. Basically what it is what's the benefit of our intervention and what are the downsides of our intervention? What's the potential morbidity? And you want that therapeutic window as high as possible. When the therapeutic window narrows, where you're getting much less bang for your buck, that's when we try to be really thoughtful about whether we should do that. So a neck dissection, actually there was a large randomized study out of India that looked at the use of neck dissection in patients with early tongue cancer and found that there was a significant survival advantage to doing it. We know that these tumors go, and that was an early stage without a lymph node. We know that they go to lymph nodes very often. This patient seems to have a very suspicious lymph node. We would get a PET CT in addition to this MRI to help confirm that. But a lymph node in this, a neck dissection in this setting can be therapeutic because it removes the involved lymph node, but also diagnostic. It's very common, no matter how good your MRIs or PET CTs are, it's very common to find microscopic lymph node disease in oral cavity cancer, very common. And what that helps is you want to try to go to the lymph nodes with the highest risk of having disease. Now, we've done tons of previous surgical pathologic studies that have shown that if you operate on tons of these patients, you figure out that if you have a well-lateralized tongue lesion, the risk of there being an involved lymph node on the contralateral side is pretty low. In a case like this, I'd say it's probably in and around 5%, 5 to 7%. It's not zero, but it's low. whereas the overwhelming majority are going to be in level 1, 2, or 3 of that left neck. If he had an extensive burden of disease, you can consider level 4 and 5, the lower neck or the posterior neck. But generally, level 1, 2, 3 is where the money is on that ipsilateral side. So we do that neck dissection for diagnostic and therapeutic purposes. However, neck dissections can have morbidity. To do a bilateral neck dissection involves a much larger incision. And there are cranial nerves, especially the 11th cranial nerve that controls shoulder function, the spinal accessory nerve, that can be damaged during neck dissections that can have morbidity. And because of that, we try not to do that unless there's bang for your buck. So that's why we, a selective neck dissection, which means not a comprehensive, take every lymph node level out, try to target the ones that are at highest risk of having disease so that we can minimize morbidity is appropriate. And that would be a left-sided only selective neck dissection, 1 through 3 or 1 through 4. And I think that's what we would have done as well.
Excellent. Thank you, Dr. Koifman. So this patient ends up going to surgery, has the partial glossectomy in the left neck dissection. So while everybody is reviewing this, Dr. Anderson, do you want to go kind of describe what you see? What are the notable details on the pathology report and how you maybe look through a synoptic table when you stage your patients? I think you might be muted.
There you go. All of this information is very helpful for radiation planning. It tells me not only what did the surgeons dissect and where have they been, but where have they not been. And so I'm looking at things like the grade, well differentiated versus poorly differentiated, and looking at the overall size. I am very interested in the depth of invasion. Let's see. There we go. I needed to move the poll window out of the way. The depth of invasion, which is a slightly different concept than tumor thickness, but tumor thickness is commented on here. We also want to look at the margin status, whether it was close or positive. We often get some sort of depth as to where the margin is closest and what that closest margin is. The more minor pathologic features of lymphovascular invasion and perineural invasion. In our tumor boards, we often talk about not just present or not present, but for the perineural invasion in particular, how extensive is that? Sort of looking together on those pathology slides, is this more of an infiltrative type of pattern, or is this a pushing border kind of pattern? Total number of nodes positive, and then whether or not the cancer escapes the lymph node capsule. That term extracapsular extension looks like was not seen here. The largest metastatic focus in the node is interesting. It's only 6 millimeters, but that doesn't necessarily influence anything. There were still 2 nodes that had cells in them. I also pay attention to what the denominator is. Sometimes we see patients who had their surgery done elsewhere, and if nodal stations only have 2 or 3 total lymph nodes in them, versus say we've got, let's see, 14, 16 nodes total here in the neck dissection, I'm much more confident that the surgery was well done. And so this looks like a very complete and helpful pathologic report. Yeah. And oftentimes the synoptic table sort of pre-calculates for you the TNM stage. So it looks like that's what our poll will assess for.
Right. I think looking at the different responses, the most common responses are T2N2 and T1N1. And in this situation, I think that it's a T2 because of the, again, there's tumor thickness and there's depth of invasion. I think this specific pathology report used both for the same line, but it was a 6 millimeters. So it's a T2 because it's greater than 5 millimeters. And there were more than 1 lymph node involved. So with 2 lymph nodes, that gets you N2B. So this patient was ultimately staged as a T2N2B cancer. And then, he recovers from his surgery. He returns to your radiation clinic postoperatively. You look at the pathology report, you see the 2 involved lymph nodes, some of the perineural invasion, 5 millimeter thickness, or at least 5 millimeter thickness. And you recommend treating the patient with adjuvant radiotherapy. Dr. Beadle, for this T2N2 oral tongue cancer, what are your targets and what dose would you use?
Sure. So just to say that he meets criteria for adjuvant radiation based on several different factors. There have been a lot of studies throughout the years looking at what in a pathology report or what on clinical findings for patients who go to surgery for oral cavity cancer predispose them to recurrence. And if they're predisposed to recurrence, for those that we should do radiation for and those that we should do chemoradiation for. For this patient, he meets criteria for radiation based on all of the things that you noted. And I would target the operative bed of the tongue where the tumor came out and the area of lymph nodes where we've identified those pathologically positive lymph nodes and take that to 60 gray and 30 fractions. I'd treat anything they dissected to 56 gray. Because in that case, there could still be microscopic disease and we've had surgical violation of that neck, which may impair healing or oxygenation. And then I was raised that the oral tongue is a central structure and that while we don't necessarily need to give the patient the morbidity of a contralateral neck dissection, because the lymphatics through the tongue do cross, the contralateral neck is at risk. So I would treat the contralateral neck lymph nodes as well to 54 gray. It's convenient that Dr. Koifman stepped off right now because I know he feels very differently about this and has published on it. But in my hands, oral cavity cancers and especially oral tongue cancers can be incredibly aggressive. If they recur, there are oftentimes very few options for these patients. And I want to make certain that I optimize their chance of cure now. So apparently this is exactly what I did because I see that that's exactly what's on the slide. So at least I'm—
There's no coincidence.
At least I'm consistent. So I do take the time to try to recapitulate where the disease was off of preoperative imaging. I feel like if you don't do that, you can lose your boundaries. And so I really try to go back to that preoperative imaging. And as Dr. Anderson said, there was a really good MRI to help guide where my targets are.
Excellent. Thank you so much, Dr.
Is there
Beadle.
any of your institutions utilizing sentinel lymph node biopsies for early oral tongue tumors these days?
They're not, although I believe NRG is going to be opening a trial of that. They haven't.
It just got approved, so there's a new trial. This patient, if we believe that node was positive preoperatively, wouldn't have been a candidate but for people who on preoperative imaging have no evidence of nodal disease, they can have a sentinel node. If it's positive, then they go for a completion neck dissection, and if it's negative, they're done at that point. So hopefully, again, to give less surgery to people who won't need it. So I think that's a great point, Dr. Anderson.
Yeah, and that also actually leads us into our case variations. But just describing the rest of this patient's course, he completes radiation. With the treatment that Dr. Beadle described, you would expect, skin reaction, taste changes, dysphagia, mucositis. He eventually has an MRI and it shows no evidence of disease, and then he's ultimately followed by the same multidisciplinary group that we've described before. So talking about different case variations for this oral cavity cancer, we mentioned, do all oral, Dr. Anderson raised the question, do all patients with oral cavity cancer need a full lymph node dissection? And so sentinel lymph node biopsy is one option. And then maybe just Dr. Sangvi, can you comment specifically on the second point? Do all patients with oral cavity cancer need surgery? Do they have to have surgery, or can we, like an oropharynx cancer, offer radiation by itself?
Yeah, so generally we think of, as Dr. Beadle was mentioning, we think of oral cavity tumors generally having a worse prognosis than oropharyngeal cancers. And we do use surgery as the primary modality for all oral cavity tumors. I would say the only exception could potentially be a well lateralized small oral tongue cancer. There are definitely older series that have used combination of both external beam radiation followed by a brachytherapy boost, which can be used as an alternative to surgery. But typically in the US, I would say most of us still use surgery as the primary modality of therapy. The other exception for oral cavity would be a lip tumor. In my practice, I treat most small lip tumors with primary brachytherapy with really good outcomes.
Thank you, Dr. Sangvi. Okay, so that ends that case. Dr. Palm, Dr. Khan, do you think we have time for one more case, or should we end it there?
I guess I just want to make sure that everyone has time to ask questions. So should we pause for a bit and see if we have any questions from the students? I think we've had some great questions in the chat box.
Yeah, so some questions about, maybe Dr. Skinner, can you expand on the question about deintensification for oropharynx cancers using lower doses of radiation or TORS perhaps?
So there is a, I hesitate to use the word glut, but that's the word I want to use, of trials trying to figure out how to maintain good outcomes or excellent outcomes in HPV positive oropharyngeal cancer while decreasing morbidity. So I think that they kind of fall into a few categories. Firstly, let's talk about the ones that we know didn't work. There were 2 clinical trials recently, 2 very large. So let's talk firstly, I'm sorry, I've just been reminded my audio kind of stinks. So let me get a little closer to the microphone. Then you can see my poor quality of my skin. But there are 2, let's talk about the negative trial first. I got 1 laugh, I feel so good about myself. So let's talk about the negative data first. There were 2 very large phase 3 randomized trials looking at the combination of radiation and a drug called cetuximab, which targets EGFR, versus standard platinum-based chemoradiation. Because there was previous data that the combination of cetuximab and RT did better than RT alone, firstly, and secondly, had less toxicity than platinum plus RT. So what did they find? Firstly, survival, which is something we cannot compromise, was lower in the experimental one. RT plus cetuximab versus RT plus platinum. It was lower. That's 1. And 2, toxicity was no better. So that basically kind of put the end on that investigatory theme. Another investigatory theme is utilizing induction therapy. Induction is basically some form of systemic therapy, some form of chemotherapy, or multiple chemotherapeutic agents to try to figure out what tumors are responsive versus non-responsive. And those tumors that are responsive could, in theory, be treated to a lower dose of radiation, maybe radiation alone, maybe a lower dose of radiation plus a gentler chemotherapy, something like that. There have been a few, primarily single institution trials that have investigated that approach. There are some very adamant believers in that approach, but it's still investigatory. And I personally would categorize the data from that as mixed. Another approach, as mentioned by myself and Dr. Koifman earlier, is utilizing transoral robotic surgery. I am neither a true believer nor a critic. I am relatively agnostic in regards to tumors at this point. For small tumors with 1 or a few lymph nodes, I think it's a reasonable opportunity to try to either dose de-escalate the adjuvant radiation, but the downside, and there was a recent trial presented at ASCO this year that basically did TORS, and then they risk adapted the treatment after TORS. So some patients, and in that trial was about 12%, wound up getting nothing afterwards. They had small tumors with 1 or no lymph nodes. Then there was a randomization whereby some got the regular standard 60 gray of radiation, and some got less, some got 50 gray of radiation. And then those that had tumors, so ECE, I don't think we talked about extra capture extension, but I don't think we described what it is. So basically, imagine, and this is one way it was described to me, to describe to patients. Imagine you got an M&M, right? With a chocolate inside the M&M and you got the hard candy shell. Well, in the summertime, it's really hot. So if you put that in your pocket, and you put your hand in your pocket, the chocolate, the thing is gonna crush and the chocolate's gonna ooze outside that candy shell. That is the cancer cells in extranodal extension. They've oozed out of the lymph node, they've oozed out of that candy shell, and that is extracapsular extension. So in these patients with extracapsular extension on that trial, they got 66 gray plus radiation, which is not a dose extension. So that's the problem with TORS. You don't know what's gonna happen until you do the surgery. And you may wind up giving the patient 3 forms of radiation, or excuse me, 3 forms of therapy as opposed to less. So that's the difficulty with TORs. Another way is just to say, well, heck with it. We're going to just decrease the dose of radiation. We're going to give the standard chemotherapy, and we're going to decrease the dose of radiation. And that's something that's being investigated at the level of NRG. But again, that's still early days. How much radiation? How much radiation de-intensification is enough to really have a positive impact on side effects? I don't know. So those are kind of the broad strokes of de-intensification trials. Right now, we're just not there. The standard, someone very, very smart in a recent presentation said the standard of care for HPV positive, locally advanced head and neck cancer is 70 gray with plaque. And that's it. That's true. So anyway, that's my expanded version of what I typed out.
Wonderful. Thank you so much. I know we prepared 6 cases, but there was so much wealth of knowledge that was given in the 2 cases that we were able to get through. So hopefully in future Rover sessions, we can do some more of these cases, perhaps next year. So I want to thank everyone for joining. We would like, we'll be sending out the post survey for this session, and you'll be entered into a raffle for Amazon gift card. So please look out for that. You can always visit our website, which has all of the resources from these sessions if you've registered, and other resources as well. You can reach out to myself or Dr. Pollum. And next slide. Just wanted to plug a few other events coming up. This is an event. This is called the Radiation Oncology Intensive Shadowing Experience. It's a 1-week experience at Harvard for 4th year students who are underrepresented minorities. So if you're interested in that, you can visit this website. The information is also on RadOnc Virtual. Next slide. There's an ACRO webinar that is going to be next week, and it is Navigating Radiation Oncology in the 2021 Match. It's a question and answer webinar for medical students. So you can tune into that and sign up or send in any questions for that. And more importantly, we have our next rover in 2 weeks. Again, on July 23rd, it'll be on gynecologic cancers as well as hematologic lymphoma cancers. And you can sign up through the website or on this link. So with that, we have 5 more minutes for any questions that anyone has or any additional comments.